controlled ultrasound-guided Tumescent Anaesthesia in Endo-venous Laser Therapy. Comparative study of an original technique with direct high-dose separation approach. Please.
Good morning, Mr. Chairman, dear colleague. I'm going to present you the controlled ultrasound-guided Tumescent Anesthesia in GSV, comparative study. So, modern technique of thermal ablation are made possible by the use of local anesthesia. It involves infiltration of a large volume of dilute lidocaine or without epinephrine in target tissues. For that, become swollen and firmness on target tissues. It is more than 1 century old. It was described in 1937, and after plane introduced to the fat tissues in a low position and extended to the other surgeries. We use it since more than 2 decades in the EVTA, but not precise details have been reported in the literature. So EVTA can be accomplished totally by local anesthesia, provide that in a weak patient, provide that the anesthesia is 100% without with the thermal protection, minimal risk. So to minimize heating of adjacent structure, we can choose either a large volume or to control the volume and the technique. So the optimal volume for the Tumescent anesthesia is not precisely defined, but the appropriate volume of the Tumescent anesthesia solution for any given volume for the target tissues is minimal volume, but will achieve complete local anesthesia. There is one more technique, more than one volume and solution, and concern could be raised about improving result in terms of accuracy and safety. So that's why we propose our technique. On the contrary, we think that we have to control the volume and the solution by the ultrasound guide. It is mandatory with its art and with its rules and incidents in the target tissues in precise area, protecting nerves and damaged nerves. And the objective, the primary objective, is no pain and thermal ablation with minimal risk, minimal elapsed time, and minimal discomfort. Concerning the volume, sufficient volume and anesthetic solution is important to achieve adequate Tumescent anesthesia, and some care and experience are required to determine the safest and most effective volume of a solution. But we have to avoid unnecessary volume, especially patients those in elderly person and with those with cardiogenic or renal insufficiency. So, according to previous study, we knew that source of pains, needle can cause an epidermic pain, the mechanical trauma from this fascia, sensitive fascia, and specifically the hydrostatic stretching in the compartment of the fascia. And finally, the acidic pH of the solution. That's why we buffer the solution to potentiate the action of the lidocaine. So our study in the prospective non-randomized to assess the short-term efficacy and safety. There were 102 awake patients with duplex morphine GSV insufficient were treated with EVLA with phlebectomy. We used the solution according to Creton study, and the objective is to define and assess our technique and divide in 2 groups. First group with a classical Tumescent anesthesia, and B with a controlled ultrasound-guided Tumescent anesthesia. We assess the pain and volume in the 2 groups, and found a statistically significant decrease in pain sensation was reported in group B. We found also a less volume in the group B than group A. We have an occlusion of 100% in both groups, until 6 months, no damage injury, no diaesthesia according to DNA scale, to a DN4 scale, and all patients test to daily activity within 3 days. So, an optimal control of the Ultrasound-Guided Tumescent anesthesia should achieve this principle, this clinically useful effect. The target pharmacology delivery, hydrosuppression, hydrodissection, hydrocompression, and the reservoir effect. The hydraulic compression may contribute to the hemostasis and exsanguination with the collapse, perivenous collapse, the hydrodissection with the collagenous spreading, perivenous collagenous spread, make a separation on the venous wall, and then, as expected, the target pharmacology delivery in situ of the lidocaine and the epinephrine make anesthesia and vasoconstriction. But I would like to show you this very important effect, the reservoir effect in the interfacial segment. It's slow, it's systemic absorption. There will be a prolonged effect. This is specific to the anesthesia in the saphenous vein. And finally, the hydrosuppression concept. We believe that more than the volume, the hydrostatic pressure contributes to a significant displacement and separation of the nerve from the venous wall. So the technique can divide it in 3 steps. The first step is neurovenous ultrasound marking, secondly pre-anesthetic dermal injection, and finally the ultrasound-guided itself. The first one is a real challenge to do a precise map of venous pattern of the small saphenous and the great saphenous vein, and its relation with the nerve, and identify the risk points, which are the point of contact with the nerve and the vein. They put the strategy, and before the strategy, we have to ask 3 main questions. Is it interfacial vein? Is it superficial or deep? And is it close to an anatomical structure we need to protect? Here you can see the saphenous point of risk, as both of you know, in the distal part of the segment vein, too close and in contact. And much less known, the saphenous point of risk in the area of the hunter, too close in the, you can see the hyperechogenic structure close to the saphenous, the great saphenous vein. So the first step, after marking the GSV, the point risks are marked by arrow, and then a cross mark on one end of the probe. Very important to place the probe perpendicularly to the venous, to the axis of the venous. The second step, to prepare the skin site where the infiltration will be inserted with a small needle, and the skillful injection. The infiltration need not to be uncomfortable and painful if it is done with gentleness and care. You have to warn the increase a certain area, groin, knee, and distally. And finally, the puncture itself with the principles. First, the liner transducer is placed perpendicular to venous axis with the saphenous vein centrally positioned. In plain view of the needle, short arcs of the vessel, then the transducer is rotated 45 inverse clockwise. You have this image to explain. And after that, you can see the image. And I decided to show you, just inside, you can see the saphenous nerve, which is rare, but we can see it in the hunter, just here, with the hydrocompression, then the hydroseparation. We don't need to inject a lot of volume, just use the bulk, the pressure of the pump to displace the nerve. So the prerequisite for training to the control of Ultrasound-Guided with the basic knowledge of subcutaneous anatomy, medical manual dexterity, experience practicing ultrasound, and empathic attitude regarding awake patient, anxiety. With the appropriate training, the controlled ultrasound-guided Tumescent anesthesia may improve results in terms of accuracy, reducing the post-procedure complication rate. It would be less painful, and it could be pleasant without systemic anesthesia. But we need more comparative studies, especially in the treatment of the SSV and the Giacomini vein. I invite you to see my video on the my video training on the SSV treatment, which will be in the website of the French Society website. Thank you.
The next speaker is Dr. Dennis Huss.